Hi, I'm Dr. Maria Corcorran from the University of Washington. In this Hepatitis C online mini lecture, I will discuss the management of HCV during and after pregnancy. The objectives of this talk are to review the epidemiology of HCV in pregnant women and risk for perinatal transmission, outline HCV screening recommendations during pregnancy, discuss factors associated with HCV perinatal transmission and impacts of HCV on pregnancy, review data for the use of DAAs during pregnancy, and discuss management of babies born to HCV-positive mothers. In 2021, there were 16,923 births to mothers with HCV infection in the U.S. The total number of pregnant women with HCV infection was highest among white individuals, but the rate was highest among American Indian and Alaska Native individuals. Studies estimate that approximately 6% of births among HCV viremic mothers result in HCV transmission to the baby. In 2021, there were only 199 cases of perinatally acquired HCV reported to the CDC, which is likely a gross underestimate based on the known number of births to mothers with HCV and the estimated transmission rate. Major guideline committees recommend routine prenatal HCV testing for all pregnant women during each pregnancy. Screening should ideally be performed at the initial perinatal visit via HCV antibody testing, with reflexive RNA testing for all individuals who screen HCV antibody positive. For pregnant women with ongoing risk factors for HCV, repeat testing can be considered later in pregnancy on an individualized basis. The mechanism and timing of perinatal transmission are poorly understood, but most infections are thought to be acquired in utero, with data suggesting that approximately 2/3 occur late in utero, approximately 1/4 occur early in utero, and the remainder occur during delivery. There are several factors that increase the risk of perinatal transmission. These factors include, number 1, higher maternal HCV viral load, although no viral threshold for transmission has been identified. Number 2, co-infection with HIV, which is estimated to increase the risk of perinatal transmission by 5%. Number 3, maternal injection drug use, which is theorized to increase perinatal transmission due to increased infection of peripheral blood mononuclear cells and/or supra-infection. And number 4, intrapartum exchange of fluids, including prolonged rupture of membranes, obstetric procedures that expose the fetus to maternal blood, and vaginal bleeding. It's notable that breastfeeding is not associated with increased risk for HCV transmission unless the mother has cracked or bleeding nipples. There are mixed data on the impact of HCV on pregnancy outcomes. Pregnancy outcomes are clearly worse among persons with HCV and cirrhosis. However, data are less clear for those individuals without cirrhosis. One meta-analysis of 9 studies found that preterm births were 62% more likely among mothers with HCV. However, a recent case control study did not find a higher rate of preterm births among 249 mothers with HCV and 486 controls. But rather, this study did show higher odds of NICU admission and small for gestational age birth weights amongst infants born to mothers with HCV. In other studies, HCV infection has also been linked to higher rates of intrahepatic cholestasis of pregnancy. Pregnancy is felt to have minimal impact on HCV-related progression of fibrosis. In fact, studies suggest that HCV RNA levels in the mother may fall after delivery, with up to 10% of HCV-positive mothers clearing infection in the postpartum period. Given this, repeat HCV RNA testing 9 to 12 months after birth should be considered to evaluate for spontaneous clearance of HCV among women who have recently given birth. Regarding treatment, there are no large-scale trials on the safety and efficacy of DAAs during pregnancy or breastfeeding. However, smaller-scale studies suggest that they are likely safe and effective. Despite the lack of robust data on DAAs during pregnancy, the American Association for the Study of Liver Disease and Infectious Diseases Society of America guidance states that treatment can be considered during pregnancy on an individualized basis after a patient-provider discussion about the potential risks and benefits. Looking more specifically at data for DAAs during pregnancy, I'd like to highlight 3 studies. The first is a phase 1 open-label trial of ledipasvir/sofosbuvir started between 23 and 24 weeks gestation in pregnant women with HCV genotype 1. This study enrolled 9 women and looked at various outcomes, including ledipasvir and sofosbuvir drug exposure levels in pregnant participants versus a non-pregnant reference group, pregnancy and infant outcomes, and rates of cure and vertical transmission. Investigators found that ledipasvir and sofosbuvir exposures were similar in the pregnant patients versus non-pregnant reference group, and all 9 participants achieved SVR12. While 5 participants had an adverse event related to ledipasvir/sofosbuvir, none were greater than grade 2, and there were no discontinuations of the drug. There were similarly no congenital abnormalities reported among infants, and no infants acquired HCV. The second study I'd like to highlight was a prospective observational study of 26 patients in India treated with ledipasvir/sofosbuvir after the first trimester of pregnancy. Pregnant women included in the study had a mean age of 28 years, and all were non-cirrhotic and treatment naive. All women achieved SVR12. Side effects were generally mild, with 27% of individuals experiencing headache, 27% experiencing nausea, and 16% experiencing fatigue. There were no reported congenital abnormalities and no infant infections. Finally, the STORK trial is an ongoing study evaluating the safety and efficacy of sofosbuvir/velpatasvir during pregnancy. As of October 2024, 50 participants have been enrolled and 46 have completed the study medications, with 2 treatment discontinuations, 1 for vomiting and 1 due to participant choice. HCV cure has been assessed in 35 individuals, with all achieving SVR. There have been no related maternal or infant serious adverse events and no cases of vertical transmission amongst 26 infants. In addition to counseling on the risks and benefits of DAAs, there are other strategies that can be used to reduce perinatal transmission of HCV. If invasive monitoring is needed during pregnancy, the Society for Maternal and Fetal Medicine recommends amniocentesis over chorionic villus sampling, as amniocentesis has not been linked with increased mother-to-child transmission. Avoidance of prolonged rupture of membranes, obstetric procedures, and intrapartum events that lead to infant exposure to HCV-infected maternal blood is also recommended to reduce the risk of perinatal HCV transmission. It should be noted, however, that there is no data to suggest that cesarean section reduces the risk of mother-to-child transmission, and this procedure is not recommended as a method to reduce mother-to-child transmission of HCV. For infants born to mothers with HCV, there are several things to note when considering HCV testing. First, passive transfer of HCV antibodies from mother to child can persist for up to 18 months in the infant and provide a false positive HCV antibody result. Secondly, transient viremia in the infant can occur in the first months of life. And finally, infants who perinatally acquire HCV can spontaneously clear their infection, just as adults can. Given these considerations, the CDC recommends testing HCV-exposed infants for HCV RNA at 2 to 6 months of age. This allows for early detection of HCV infection while minimizing the detection of transient viremia very early in life and avoiding antibody testing, which can be falsely positive due to maternal transfer of antibodies for up to 18 months of age. For exposed infants who are not tested for HCV RNA between months 2 and 6 of life, catch-up testing can be performed with HCV RNA between 7 and 17 months of life. Children 18 months of age and older who were not previously tested can undergo HCV antibody testing with reflexive RNA. Children with perinatally acquired HCV can begin treatment as early as 3 years of age. The same direct-acting antivirals used in adults are also approved for children without cirrhosis or those with compensated cirrhosis. It should be noted, however, that these medications need to be dosed based on weight in children as opposed to the fixed dosing in adults. These regimens include 8 weeks of glecaprevir/pibrentasvir for all genotypes, 12 weeks of sofosbuvir/velpatasvir for all genotypes, and 12 weeks of ledipasvir/sofosbuvir for genotypes 1, 4, 5, or 6. To summarize, approximately 6% of births among HCV viremic mothers result in HCV transmission to the baby. Routine prenatal HCV testing is recommended for all pregnant women during each pregnancy. Pregnancy outcomes are worse among persons with HCV and cirrhosis. However, data are less clear for those without cirrhosis. There are no large-scale trials on the safety and efficacy of DAAs during pregnancy or breastfeeding. However, small studies suggest that they are likely safe and effective. AASLD and IDSA guidance states that treatment can be considered during pregnancy on an individualized basis. Infants exposed to HCV in utero should have HCV RNA testing performed at age 2 to 6 months. And most children with perinatally acquired HCV can be treated with frontline DAA regimens starting at 3 years of age. To learn more about hepatitis C, please check out our online hepatitis C curriculum, which contains a variety of lessons, cases, and slides to reinforce your knowledge. Thanks for joining me today.
The production of this Hepatitis C online mini-lecture was supported by a cooperative agreement from the Centers for Disease Control and Prevention, CDC, RFA, PS 212105. This project is led by the University of Washington Infectious Diseases Education and Assessment Program.